Hi, my name is Leonel Rodriguez. I'm a pediatric gastroenterologist at Yale University. I am here today to talk to you about esophageal functional and motor disorders in children. I wanted to take this opportunity to thank ANMS for the invitation. These are my disclosures. This is the agenda of what we're going to be discussing today. We're going to divide the presentation in three groups based on the predominant symptom that these disorders may manifest with. The first group will be those presenting primarily with regurgitation and heartburn, which includes gastroesophageal reflux disease. Of note, we're going to mention or discuss only those with common symptoms, typical symptoms, not those with extraesophageal manifestations, those with esophageal hypersensitivity and functional heartburn. We're going to discuss also about those presenting primarily with dysphagia, which includes primarily achalasia, and we're going to briefly discuss others. And at last, we're going to talk about those presenting primarily with chest pain, which includes primarily disorders of the esophageal peristalsis, primarily hypercontractile esophagus and distal esophageal spasms. Most of the conditions that we're going to discuss today manifest in children in a similar manner as in adults, with some exceptions related to patient age and size, and also because of the paucity on pediatric data, because of how rare this disease can be, and also because of lack of normative pediatric data. Some information presented is extrapolated from adult data. So let's talk about how do these symptoms manifest. What are the most common symptoms for esophageal motility disorders? Most of the times, patients will present to us with symptoms including regurgitation, heartburn, dysphagia, and chest pain. We know that regurgitation may result from defective protective mechanisms or poor esophageal compliance. Heartburn might be related to regurgitation, but also to hypersensitivity and hypervigilance. And dysphagia may result for poor transit, and chest pain may be related to spasms, also to hypersensitivity. The predominance and intensity of each symptom varies by disorder. For example, regurgitation and heartburn are predominant in GERD, dysphagia in achalasia, and chest pain in disorders of peristalsis. How do we evaluate those patients? At all ages, we know that the symptoms vary by age. Infants will present primarily with regurgitation and feeding difficulties, but they may also present with aversion, arching, and other non-specific symptoms. Children will present primarily with regurgitation and potentially with some heartburn. And adolescents will present primarily with heartburn, which mimics more like the adult presentation. The evaluation is aimed in pediatrics at ruling out other conditions that may mimic reflux, and also to evaluate for red flags and treat those accordingly. Those include constitutional, which may point towards systemic conditions, neurological red flags, which may point towards increased intracranial pressure that might be the reason for the GI symptoms, and other GI symptoms, including forceful vomiting or abdominal distension that points towards mechanical problems. We typically divide evaluation at this point based on age, as infants and children and adolescents behave in a different manner. We follow typically the guidelines by the North American Society for Pediatric Gastroenterology. So let's start with infants. Infants are more likely to present with regurgitation due to anatomical problems, so we tend to have a lower threshold to investigate for those. The first intervention that we do is to adjust the volume or the frequency of the feeds to avoid overfeeding. There is no good evidence for this intervention, but it's an intervention without any associated risk if it's carried out properly. The next intervention is aimed at increasing viscosity. We achieve that by thickening feeds. There is a lot of work being performed at the moment in this topic. All the preliminary studies are showing a clear benefit on regurgitation, but not so clear in other symptoms. It is important to mention specific situations that might be useful for the pediatrician and for the general gastroenterologist that is treating these conditions, which include to avoid the use of rice cereal that has high contents of arsenic, and also to use commercial thickeners for breast milk to avoid the potential for the amylase digesting the rice cereal. The next step is diet elimination. We accomplish that by using hydrolase formulas or amino acid formulas in those that are formula fed, or elimination of dairy from maternal diet. There is also no good evidence for this, but it is very difficult to differentiate between these conditions because the symptoms are very similar. The next step is acid suppression. We use either an H2 blocker or a proton pump inhibitor. There is no evidence for the efficacy of acid suppression in infants in terms of GERD symptoms. So we use it as a trial only on those that have not responded to the previously mentioned interventions. If that doesn't work at this point, we recommend to evaluate for other causes and consider further testing and evaluations. If you perform an imaging study, if it hasn't been done at this point, or proceed with an endoscopy to look for mucosal reasons for the symptoms at this moment. So let's talk about children and adolescents now. The first intervention that we do is dietary and lifestyle changes. If that doesn't work, we recommend a trial with acid suppression. This should be carried for a minimum of 4 to 8 weeks. And when that doesn't work, or when we are not able to wean those after a few weeks, 4 to 8 weeks, we recommend to proceed with an endoscopy. This one is helpful to differentiate between mucosal conditions that can be associated to reflux symptoms like eosinophilic esophagitis, and also potentially to rule out other anatomical problems. In those, when the endoscopy is normal, we recommend to proceed with a pH impedance with 2 primary objectives. 1, to evaluate the esophageal acid exposure, and 2, to evaluate the symptom correlation. For the esophageal acid exposure, for those that have abnormal esophageal exposure without esophagitis, those are the ones that are being labeled as non-erosive reflux disease. Those that have normal esophageal exposure, we pay careful attention to the symptom association. Those with positive symptom association are labeled as hypersensitive esophagus, and those that have negative correlation are labeled as functional heartburn. It is important to mention that we still consider those that have abnormal acid exposure as to be part of the reflux category, and those that have only a symptom association or no symptom association but no normal esophageal acid exposure as part of functional esophageal disorders according to the wrong criteria, classified in adults but has not been truly validated in pediatrics yet. So let's talk about gastroesophageal reflux disease now. As you know, it's the most common and most investigated esophageal disorder in children. Some studies reporting up to 25% of infants and even 10% of children experience GERD symptoms at any time. The symptoms in pediatrics vary according to age, as most of the conditions that we're going to be discussing today. There are different mechanisms that can explain this, including transient LES relaxation, low LES resting pressure, and mechanical problems that usually are present more likely in adolescents that include like a hiatal hernia or sliding hernias. The diagnosis is clinical in the majority of the patients. It's important to pay special attention to rule out conditions that resemble GERD, like gastroparesis, functional dyspepsia, and rumination syndrome, amongst others. It is important to put some emphasis on identifying red flags that may require a change in approach. The response to the PPI trial in older children supports the diagnosis. So let's talk about treatment now. The goal is to relieve the symptoms and prevent complications. Many will respond to dietary changes and sleep hygiene. Those dietary changes include avoid large meals, spicy food, late meals. You know, many of those are common sense, but there is no evidence for those. There is also no evidence for low calorie and low fat diet. The next step is acid suppression, especially high dose PPI at this point, which includes BID dosing. The PPI response varies among all different conditions, with the highest response on those with erosive esophagitis, and the ones responding the least are those with functional heartburn. There is no evidence for prokinetic use in gastroesophageal reflux typical symptoms in children. I think the message is, if you need to use a prokinetic, you're not treating GERD, you're probably treating regurgitation from other causes. How about other types of interventions? Endoscopic interventions, there is no evidence to support the radiofrequency ablation or placation or other type of endoscopic treatments in children. In terms of the fundoplication, there is ample literature reported the high success for symptom control and decreases esophageal acid exposure both in adults and also in kids. The response is variable for extraesophageal symptoms. It's important to mention that this comes with potential complications in up to 20% of patients. That includes dysphagia, early satiety, bloating, retching, and important, the symptom recurrence. Like some patients might even up to like 15-20% of patients will have symptom recurrence at some point. This is recommended primarily for patients that have complications from long-term PPI use, those that have symptoms that are refractory to all the above mentioned interventions, or have life-threatening complications. There is no evidence to support transpyloric fits or esophagogastric dissociation in pediatrics. This merits a little bit more further evaluations and taking care of special considerations like patients with special needs that might potentially benefit from these from different etiologies. So let's talk about now esophageal hypersensitivity. Basically, it's heartburn that it correlates with reflux episodes that have in patients that have normal esophageal acid exposure and they do not have esophagitis. The mechanism seems to be hypersensitivity and hypervigilance. There is still some debate between if this is a variant of reflux or esophageal functional disorder. Why do we say that? Because there is normal esophageal acid exposure, but they respond to high dose acid suppression and they do respond to surgery. There are also reports stating that there is comparable rates of other functional disorders like IBS compared to NERV, but they are lower than those with functional heartburn. How do we treat this condition? Unfortunately, there is a significant paucity on the data on treatment of esophageal hypersensitivity in children. In terms of medical treatment, the PPI trial is using high dose or BID dosing is still probably the #1 recommendation in pediatrics. We do use pain modulators as the second treatment or sometimes as an adjunct in the treatment. In terms of surgical interventions, we know that the fundoplication is associated to positive outcomes in adults. However, there is no evidence to support its use in children at the moment. Let's talk about functional heartburn now. This is heartburn that does not correlate with reflux episodes in patients that have normal esophageal acid exposure and no esophagitis. How do we treat these patients medically? We typically use high-dose PPI, either high-dose or BID or both, and we pair that with pain modulators. We do recommend more behavioral interventions as well as using complementary medicine. In terms of surgical treatment, we know from adult studies that there is not a great response to fundoplication in this group of patients, despite a recent study showing otherwise. There is no evidence in pediatric to support its use, given the lack of reports. In summary, you know that GERD is the most common esophageal disorder. Many will respond to dietary and lifestyle changes. PPI is the therapy of choice, especially for erosive esophagitis and those with symptoms refractory to previous interventions. Surgery has a specific but limited role in pediatrics. Esophageal hypersensitivity is being identified in children despite the paucity of data. PPI and pain modulators are the primary treatment, and there is no evidence to support surgery in children at the moment, although we see that as a potential treatment, especially in adolescents. Functional heartburn is also being identified in children. PPI and pain modulators, as well as behavioral interventions and alternative medicine are the mainstay therapy with no role for surgery in children. So let's talk now about esophageal disorders associated to dysphagia. How do we evaluate those patients? This is the algorithm that most of us follow when we see children presenting with dysphagia. It's very important to perform a thorough medical history and physical exam to try to establish the location of the dysphagia as either oropharyngeal or esophageal. Sometimes it's not complicated. The patient will present with choking and gagging with fits, so you will quickly make the diagnosis of oropharyngeal dysphagia. But sometimes patients with esophageal dysphagia might have enough food retention in the esophagus that may present with similar symptoms. In patients with oropharyngeal dysphagia, I'm going to briefly mention this. It's not the main topic of this discussion. We aim the next step, which is imaging studies at trying to evaluate for anatomical reasons, and the endoscopy to evaluate for mucosa, and also to, for anatomical reasons, and the manometry to evaluate for esophageal motor dysfunction, specifically at the upper esophageal sphincter level. For esophageal dysphagia, the imaging study might be normal or abnormal. When it has an abnormal anatomy, you treat that accordingly. Either you have a stricture, you have a congenital web, or you have other types of anatomical problems. The endoscopy is useful primarily to rule out other conditions that may cause dysphagia, like eosinophilic esophagitis. In patients that have, at this point, that have normal studies, the next step is to perform a high-resolution esophageal manometry. In patients with oropharyngeal dysphagia, I just want to make a quick parenthesis here and mention that, unfortunately, in pediatrics, when everything is normal, these are the ones that we typically label as globus, when clinically we should be able to make that diagnosis without requiring all these. And in pediatric patients with esophageal dysphagia, when everything else is normal, is when we typically make the diagnosis of functional dysphagia. So let's talk about high-resolution manometry and the utility for esophageal disorders in children. The high-resolution manometry in children is performed with the same equipment and using the same parameters that we use in adults. Using the DCI, the IRP, and using the distal latency as well. However, there is no pediatric normative data. The Chicago classification is not validated in children. And to compound this even more, there are some pediatric studies that have shown that some metrics of the Chicago classification are age and size dependent, so they need to be adjusted whenever we do our calculations to make a diagnosis based on high-resolution manometry. If you want to have a better overview of high-resolution manometry, I would recommend to see those two videos about webinars from ANMS in terms of like when and how to do high-resolution manometry. So let's talk about how do we evaluate dysphagia based on high-resolution manometry in children. We follow algorithms very similar to what adults do. We evaluate the IRP and peristalsis, and those that have increased IRP and abscess peristalsis is what we label as achalasia. Those that have elevated IRP but normal peristalsis, we label them as EGJ outlet obstruction, and it could be an early presentation of achalasia, or most commonly in pediatrics, a mechanical obstruction. Typically, congenital strictures, rings, or other types of malformations. Those patients that have normal IRP and normal peristalsis, but they tend to have either decreased latency, tend to be diagnosed as distal esophageal spasms. So those with elevated DCI over 8,000 are diagnosed as hypercontractile esophagus. Those that have normal IRP and abnormal peristalsis are labeled as abnormal peristalsis variants. We rarely see these in pediatrics, but we do see it every once in a while. We don't understand the meaning. We still do not know what does it mean, but we follow them over time. And those that don't have any abnormal finding, we call them normal. For the purpose of this talk, we're going to concentrate on achalasia and on those that are presenting with disorders of esophageal body peristalsis. So let's talk about achalasia. This is extremely rare in children. When I tell you rare, extremely rare. It's about 0.1 for every 100,000 patients, children, which means that it's about 5% of all achalasia patients. So in other words, for every patient that we see in pediatrics with achalasia, our adult colleagues will see around 20. The presentation varies, which makes the diagnosis complicated sometimes. And the diagnosis is usually between 7 and 15 years of age, but they can present early in life, even premature. The symptoms vary with age, ranging from like GERD-like symptoms to dysphagia and weight loss. It is important to mention that infants are very particular in the way that they present, because sometimes they present with very atypical symptoms like cough, aspiration, hoarseness, feeding issues, aversion, while older children might present with the more classic dysphagia and weight loss, and also with chest pain and food impaction. The diagnosis can be delayed because of these reasons. It's important to keep it in mind when you have patients with presenting with these symptoms. There are associated disorders in pediatrics like trisomy 21, congenital hyperventilation syndrome or Haddad syndrome, familial dysautonomia, AAA syndrome, Alport, or Moya-Moya 6. There are other conditions that have been associated in pediatrics too, like cerebral ataxia or neurofibromatosis, and some others that are more predominant in adults like Parkinson's and Chagas. So how does achalasia happen? All of us believe that there is some genetic susceptibility. There are specific HLA types that are associated with a higher rates of achalasia. And there are neurotropic viruses like herpes simplex, HPV, and others that might trigger an autoimmune response that is mediated primarily by T lymphocytes and anti-neuronal antibodies that are targeted against the enteric nervous system. This results in a loss of inhibitory myenteric neurons that creates an imbalance between excitation and inhibition and results in a loss of peristalsis and LES function. How do we diagnose these patients? It's suspected by clinical history in most patients. Most of us will recommend an imaging study to start. Some changes that you can see in a plain chest X-ray include a widened mediastinum or air fluid levels, or in contrast studies, you can see esophageal dilation, you can see the classic big sign or poor esophageal emptying. Endoscopy is usually normal and useful primarily to rule out other conditions that mimic achalasia, like eosinophilic esophagitis. Esophageal manometry is the gold standard for diagnosis, demonstrating aperistalsis and incomplete or non-relaxing lower esophageal sphincter. The hallmark is absent peristalsis and absent LES relaxation. This can be very variable in children. There are reports showing that up to 40% of the patients can have normal LES relaxation. As with adults, there are 3 subtypes of achalasia that are observed in children based on high-resolution manometry. Type 1, type 2, and 3. Type 1, which is associated with 100% failed peristalsis. Type 2, that has more than 20% of panesophageal pressurization. And type 3, with more than 20% of spastic swallows. How do we treat these patients? The goal is to reduce the LES resistance to improve the bolus transit. And then the pharyngeal pump and the gravity may be enough to propel the bolus distally. Medical therapy is very limited in pediatrics because of the significant side effects and how difficult it is to manage these side effects in children. The use of botulinum toxin injections in children has a very limited role. There are studies that report how useful it is with a mean duration of up to like 4 months. But however, we recommend it to be used only as a diagnostic aid. In equivocal cases, you have a patient that has dysphagia and the manometry shows somehow variable relaxation. And then if you treat the LES with Botox and the symptoms improve, then you feel a little bit more comfortable that the diagnosis might be achalasia. And also for temporary relief in those that are poor surgical candidates. The current recommendation is either pneumatic balloon dilation, surgical myotomy, or a POEM. Pneumatic balloon dilation. This is commonly performed with the Rigiflex balloon, which is suitable for children probably 9 to 10 years of age. We wouldn't recommend to use it in younger children. This is an example of how the balloon looks. In younger children, actually, some of us have used the through the scope balloon. And now with the new technology like the EsoFlip, that might be an option to utilize the balloon that is 20 millimeters. The Rigiflex requires anesthesia, endoscopy, and fluoroscopy. And there is a sequential balloon dilation from 30, 35, and 40 millimeters. The goal is to obliterate the waste at the G junction, as can be seen here. What information do we have about the use of pneumatic balloon dilation in children? We actually have several case series. There is this one, for example, using a single dilation in 12 children that showed a clinical improvement in all of them, even on the time esophagram. There is this other one that showed a 93% clinical success of serial dilations in 14 children, with only 7% of them requiring a myotomy after undergoing the dilations and no complications. There is this other one that reported an 87% of success after 3 dilations with potential complications like chest pain, bleeding, and perforation. How about surgical myotomy? This can be performed open or laparoscopic, thoracic or abdominal, with or without fundoplication. This is a report of 15 children followed for a mean of 32 months, of which 13 had a good response without complications. There are other studies that have reported success with Heller myotomy, specifically with abdominal or thoracic. Important to mention that those with the abdominal approach without a fundoplication have a little bit more reflux, and those with the thoracic have a little bit of reflux because they did not undergo fundoplication, but they have less recurrent dysphagia. And then this is a report of like the utility of the intra-O high resolution manometry to confirm the adequacy of the myotomy, in which resulted in improvement in children. How about balloon dilation versus surgical myotomy? There is a randomized study in adults of 200 patients. This is a landmark paper that showed no difference on the Eckhart score, the LES residual pressure, esophageal clearance, and quality of life, with different degrees of complications. There are no randomized studies in children, as expected, and they're all retrospective, and the results are variable. So, for example, there is this study of 30 children that showed that 100% of recurrence in those that underwent balloon dilation, and half of those that underwent Heller myotomy. And the interventions, of course, because they recur more in balloon dilation, they require more interventions than those that underwent Heller myotomy. There is another study with 14 children that showed the opposite, that balloon dilation had better results at 6 and 24 months. And there is a last study that with 40 children that showed no difference. So in general terms, I think that we agree with, like, even with the small studies that we have, that balloon dilation and Heller myotomy seem to be equally effective in children. How about POEM? This is a new technique using an endoscopic created submucosal tunnel to perform a myotomy. There are encouraging results in adults. There are small series in children also reporting improvement, both in symptoms and transit with bearing. However, there are no long-term studies, but there are promising results, and we believe that it could be the treatment of choice in the future. However, this is limited in pediatrics because in order to acquire or achieve mastery, you need a large number of cases, and which is very problematic in pediatrics. So what do we do with those with persistent symptoms? We know the recurrence is high. Most of the times it's related to incomplete disruption of the functional obstruction or in those that undergo fundoplication. The evaluation of those includes an esophagram to evaluate the GE junction. We repeat the manometry to assess the residual IRP. And we also have been using esophageal transit time by nuclear medicine to try to evaluate retention. Most respond to another type of intervention. So in other words, what we typically do in pediatrics is that those that had surgery and fail will undergo dilation afterwards, and those that undergo dilations and fail will undergo surgery afterwards. The success rate is significant, significantly high. In general terms, we believe that this is a decently benign condition. So let's talk about the esophageal disorders associated to chest pain. Distal esophageal spasms. This is a very rare finding in adolescents. Most of the times it's associated to reflux, and it can also be associated to an early presentation of achalasia. The high-resolution manometry demonstrates that 20% or more of the swallows with premature contractions. The treatment, because it's related to reflux in most occasions, we do recommend the use of proton pump inhibitors or acid suppression. We do use pain modulators as well. The response to muscle relaxants, calcium channel blockers, and nitrates is very limited in pediatrics as well as for prokinetics. Probably the most important aspect of this disorder in pediatrics is the fact that could be an early presentation of achalasia. So it is important to make the family and the patient aware of this so they're not lost to follow. Hypercontractile esophagus. This is also a very rare finding in adolescents. It is manifested by chest pain and dysphagia, and there is an overlap with reflux. The high-resolution manometry demonstrates that 20% or more of the swallows are hypercontractile with normal IRP. There is a current theory that there is an excessive cholinergic drive with abnormal inhibition that may cause some discoordination between the circular and the longitudinal smooth muscle causing the spasms. How do we treat this condition? We treat it very similar to the condition that we discussed previously. PPI is the first choice. We do use pain modulators. We do use muscle relaxants, even though there is limited evidence in children. There is also potential for calcium channel blockers, nitrates, and sildenafil with limited results in adults and no real evidence in pediatrics. There are adult controlled trials of botulinum toxin with variable results. We do not recommend this as a treatment in pediatrics. And there is also limited data on surgery in adults. We do not recommend this in pediatrics. The consensus in children is to be more conservative. So in summary, for disorders associated to dysphagia and chest pain, achalasia, the diagnosis can be delayed in many cases. With the advances of diagnostic techniques now that allow for earlier and more precise diagnosis and potentially to classify the disease in the subtypes and maybe guide therapy. Balloon dilation seems to be equally effective to Heller myotomy in children as it has been demonstrated in adults. The therapeutic decision in children should be based on center's experience and family's preference. Typically, what we recommend for this is that if at your center, the surgeons are very experienced in performing Heller myotomy and there is not a lot of experience in dilation, surgery should be offered as the first option. and the vice versa if there is plenty of experience with balloon dilation, but the surgeons don't have a significant experience with heteromyotomy. Also, we like to involve the family in these decisions, especially when both options are readily available in the institution. We know the relapse in children seems to be high, so we need to be prepared for that and anticipate for that. For distal esophageal spasms, we know it's a rare condition in adolescents. Because it's being seen as an early presentation of achalasia, it's important not to lose to follow this patient. We always recommend conservative therapy in children. For hypercontractile esophagus, it's also very rare in children. And we also recommend conservative therapy as the initial treatment in pediatric patients. Thank you.